Okay, so you should see that it's starting to record. Perfect. Okay, wonderful. Well, welcome everyone. I'm Dr. Megan Aston, Director of the Center, and I would like to begin by acknowledging that we are in Mi'kma'ki, which is the unceded and ancestral territory of the Mi'kmaq people. And just to take a moment and welcome everyone, to be mindful of the land that we are here on. And we have two presenters today. I would like to introduce Sarah Keeping, who is a PhD candidate, and also Chloe Flynn, who is an MScN student, and they're both registered nurses. So I'm going to turn it over to the two of you, and just thrilled to have you here and really excited to spend the time together and hear what you have to share with us. So go ahead.
Perfect. Thank you, Megan. So today I'm Chloe. This is Sarah. Thank you all for coming today. We're going to talk a little bit about a study that we've been working on. So today we'll be presenting the study that's on characterizing nursing medication management, specifically in the pediatric acute care setting. And we used a safety to mixed methods observation approach. So first we want to acknowledge kind of how this study came about. So our RAB went through, it's all been approved, the study has been started, and we have some preliminary results that we're going to share with you guys today. Our principal investigator is Dr. Janet Curran, and this work is being completed with the help of the Strengthening Transitions in Care Lab at the IWK.
So a little bit of background about kind of why this study came to be. So we know that medication management is a very frequent and key process in the provision of high quality nursing care, especially in acute care settings. But about 1 in 30 patients are exposed to preventable medication errors during their medical care. And medication management tasks are really a collaboration between lots of different healthcare providers, nurses, physicians, pharmacists, as well as patients and families. And these tasks include things like prescribing, transcription, dispensing, administering, documenting, and monitoring. And often in nursing, anyone who's listening who is a nurse would be familiar with the rights of medication administration. So things like right patient, right medication, right time, right dose, right education, right route, et cetera, et cetera. And these things kind of guide the verification of medications and influence medication safety. So that's kind of what the literature has been using historically to guide medication practices, but there's not very much acknowledgement of like the workflow and the environmental and individual complexities that influence medication management by nurses. And the extent to which nurses can facilitate safe medication management is influenced by a lot of things. So it's influenced by their individual knowledge and as well as their ability to negotiate and assess risk within their work environment. And most of the literature that has explored medication administration, there's been multiple reviews and studies that have taken place. They really focus on medication errors. But we really wanted to take a different approach, a more proactive approach to looking at medication administration and management. So we chose to take a safety 2 approach to this. So a safety 1 approach is kind of that error-focused, responsive approach to medication safety. So exploring why errors happen and targeting them that way. Where safety 2 recognizes that health systems are very complex and that a proactive approach to addressing human behavior is really key in managing this complexity. So that's what we kind of, that was the philosophy that we kind of adopted when we started this study. So that being said, our main research objectives for this study are to 1, characterize nurses' activities, tasks, and workflow related to medication management through observation. 2, describe the workflow adjustments and variability in medication management between individual nurses and work environments and settings. And 3, explore the perceptions and experiences of individual and work system factors that influence medication management. And we did this through, or will be doing this through 3 different phases.
So our first phase was to develop the actual checklist that we used during the observations. This was done in a previous study with Sarah and I and other individuals as well. So the first step with this was to identify the steps of medication administration, which includes, like Sarah mentioned, the rights of medication, and the different factors that impact the process of medication administration and preparation. So we began by breaking down the medication administration process into different sections, and we identified 4 different sections, which were translation, preparation, administration, and documentation. So the checklist accounts for a variety of different things that can happen, including interruptions and multitasking. The difference between the two would be an interruption is something that would take away the nurse from the task that she or he is currently doing. Whereas multitasking would be they're maybe having a conversation with another person while continuing to prepare the medication or continue to give a patient a medication. With this information, we developed our preliminary checklist, and then we actually did think alouds with nurses who work with medication every day, to understand what we could observe and what things were likely to be missed just by watching. Once we had all of this information, we edited the tool and then we transferred it to Wombat, which is a software program that allows us to have the checklist in a way that we can just click buttons as we watch the nurses work. Once we had it all transferred into Wombat, we then did some pilot testing with nurses. Both Sarah and I went to observe the nurses so that we could compare the data to each other's to make sure that we were both on the same track when using the tool. So this is the paper that I spoke about earlier that we used, that we developed to make the checklist. So this is just some information for you guys if you have interest in reading the paper. And this is our checklist. So you can see here, it's pretty big. I had to split it up into 2 sections because I couldn't quite fit it all on one screen. But you can see that we've split things up. So our location is at the top, and that is a mandatory field. So no matter what we're doing, we always have to say where we are. And then we have transcription and translation. We have our preparation, our administration, and our documentation. And then we also have our patients. So how many patients is the nurse looking after? Is it their own patient that they're bringing a medication to, or has another nurse asked them to grab a medication for one of their patients? And then we have multitask and interruption as well. So like I had said, a multitask, we would click if they're continuing to do the medication task at hand, and an interruption would be if they have to completely step away from what they're doing. And then this just kind of shows you a little bit of how we use it. So if you see, we have quite a few sections where we have drop downs. All we have to do is click that button and then you can scroll through it. Some are bigger than others for type of medication prepped. There's quite a few different versions of medications that you can give, so it's quite lengthy, but you can just scroll through there. You can click multiple options. As you see here, we just open it and then you can click however many is needed that's happening at that time. And then on this slide, I wanted to show you in our task section, off to the left side, you can see that everything's broken down into time. So a lot of this tool is used around time. Once we end a task, it stamps that time frame, and everything done within that period shows up as happening within that time. You can't use it in a way that like every time you click a button in one task is all going to be assumed that it was clicked all at the same time. So you have to go to next task every time you want a new time recognized. So our second phase is actually starting the observations. This was done with non-participation observations. So we essentially stood in the corner and stayed out of the nurses' ways while they worked. We tried not to interfere with anything that was going on because we ourselves did not want to be an interruption to the medication process. We did 3 to 4 observations with each participant, and the observations were about 1 to 2 hours in length, depending on how much time they were spending with medication administration. And each participant was followed by only one observer for consistency, mainly so that the nurses were comfortable with us when we were there and they didn't feel any stress on top of giving the medications to the patients. And then when we look at data analysis, we used descriptive statistics with, as I mentioned, the main focus on time. So we broke it up into a few different things. We looked at time spent in each location. We looked at time spent by the task that they were doing. So whether it be they were preparing the medication or administering the medication, or if they were in interruptions or multitasking. So some of the results that we got, they're just preliminary results so far, but we have done observations on 2 pediatric units, one being a medical surgical unit and one being an emergency department. The medical surgical unit we have finished on. The emergency department we're not quite done of yet. So we don't have a whole lot of information, but we'll give you guys a little bit. But some of the preliminary results from the medical surgical unit, we did 12 observations with 4 nurses. There were 34 total patients, and most days the nurses that we were following had about 3 patients that they had assigned to them. So 3 patients that they had to manage medications for. However, that did not always mean that every patient had medications. Some patients sometimes had more, some sometimes didn't have any. And on this unit, we spent a total of 12 hours and 51 minutes observing the nurses. And the average observation time was about 1 hour and 4 minutes.
Yeah. Okay. So some of the results kind of by location and task type. So of the total observation time on the medical surgical unit, about a third of the time was spent in the medication room, so about 4.5 hours-ish, which makes sense and we were expecting. About 32% was spent at the bedside with patients, either administering medications or doing medication-related tasks, so about 4.2 hours. And then what kind of surprised us from the data was that the next most common location for nurses was the hallway. So about 3 hours of the total observation time, nurses were either walking in the hallway, engaging in a conversation or an interruption in the hallway. So about 3 hours of that time was spent, and some of our nurses were pretty surprised about that result, and we'll talk about that a little bit later. Some of the other locations that we tracked were like the nurses station, utility rooms, treatment rooms, but compared to these 3 locations, there wasn't a whole lot of time spent there. By task type, about 16% of time was spent dispensing medication, so taking it out of the electronic computer system that stores the medications. 26-ish% of the time spent preparing medication, so about 3.5 hours. And this would vary depending on the type of medication that was being prepped. Obviously, taking a pill out of a bag and putting it in a cup would take much less time than preparing an IV antibiotic or something like that. And about 12.5% of the time was spent actually physically administering the medications to patients, so about 1.6 hours. So I guess this just kind of shows how much time nurses are spending on the non-administration related tasks to medication. I think sometimes in the literature, the focus is really on that administration physically to the patient, but clearly nurses are spending a lot of time in those tasks prior to administration, like dispensing and preparing as well. And again, the administration times were variable depending on the type of medication. So an IV medication or medication that's going through a central line was taking more time than giving an oral medication, for example. And this is some results related to multitasking and interruptions. So we have it broken down in tables here to kind of show what type of multitasking and interruptions nurses were engaged with. So a lot of these were, a lot of the multitasking that occurred was related to conversations with patients and families. So we would see nurses going in to administer their medications, but as they were doing that, they were also talking to family caregivers about the plan for the day or about patient care related things. And so they spent about 1 hour and 10 minutes of the total observation time multitasking in that way. So either providing education to families or having conversations. And in terms of interruptions, a lot of the interruptions were related to supplies. So nurses either realizing they didn't have everything they needed once they got to the room, or there was something missing in the medication room that they had to go elsewhere to grab. So that was in terms of total times, that was the most common interruption. But again, there was also family and colleague conversations that were causing interruptions as well. So in total, about 4 hours or 30.31% of the total observation time, nurses were engaged in multitasking or interruptions while they were managing medications. And we think that's obviously very significant and not really represented in the literature. In a perfect world, we want, of course, the medication process to be independent and to be, as individual as possible in terms of interruptions and multitasking. But in reality, on a busy inpatient unit, clearly that is not what's happening. And we just really wanted to highlight how significant that time is in terms of nurses engaging in multitasking and interruptions while they're also trying to manage medications for patients. In terms of the emergency room results, it was much different in this setting. So we have so far done 11 observations with 3 nurses, and we have actually more observation time in Emerge for almost 16 and a half hours. But 11 hours and 25 minutes of that time, so a huge percentage, was spent watching non-medication related activities. So those things we didn't capture because of the focus of the study. So it just highlights how unpredictable it is. On an inpatient unit, typically there's standard medication administration times. So we were able to really plan our observations well in the inpatient unit, but in the emergency department, it's so unpredictable that those medication tasks really can be hard to capture. So hopefully we'll have some more data on the emergency department as we continue with our observations, but as of right now, we don't have as much to share. So after the observations were done on the med-surg unit, we started with focus groups, and we did 2 focus groups with participants from the medical surgical unit. So we did one with nurse participants that we observed, and then one focus group with managers and leadership from that unit. And we used open-ended questions, and we provided participants with some preliminary results similar to what we're sharing today, and really used the opportunity to get some context from them and get their input on how they felt about the results and the things that impact their medication practices. We haven't done formal analysis yet, but we will be doing combined deductive content analysis and inductive thematic analysis. And I do have a couple of quotes that I pulled from the transcripts just to share some of the data that we did get. So we had a nurse participant in the first quote there kind of talk about the hallway interruptions because we had shared how much time was spent in the hallway. And she talked about how often you're going down the hallway with a bunch of meds in your hand and a parent stops you in the middle of what you're doing. And sometimes what they need is really important. So it does take you away from those medication tasks. Another nurse spoke to how they've just kind of adapted to work with distractions, and they're used to, 10 things going on all at once, and how they're used to answering questions while they're reconstituting medications, which of course is not the safest practice, but that is the reality of working in a busy acute care setting. And then one of the management participants spoke to just the potential of interruptions and noise and chaos being very high, especially at busy times of the morning, like 8 a.m. when everyone's meds are due, but all of the doctors are doing rounds and all of allied health is showing up. So this is just a few examples of some of the context that we were able to get from our focus groups.
So looking at our next steps, we, as we mentioned, have done one observation on a medical surgical unit and one on an emergency department unit. We are hoping to complete more observations on 2 other units to collect more data and compare them with the other units we have been on so far. We're also hoping to do a little bit more in the emergency department, as you guys have seen that we don't have a whole lot of medication information from our observations there. We're also going to be moving forward with doing the focus groups. We have only been able to do those on one unit so far, so hoping to get some more perspective from other nurses as well. And then one thing that we're also going to be looking at doing is comparing the data with pre and post OPOR observations. So the observations that we have done so far have all been before OPOR was put in place. So the next ones that we do will be following the implementation of OPOR. So it'll be interesting to see how that differs in medication administration and management. And then we'll also do some data integration and follow-up. So kind of putting the information into the units that we were observing on, presenting them with the information and seeing how we can move forward to make it a more seamless approach for nurses to complete medication administration.
And just to add something, for anyone who isn't familiar with OPOR, it has been implemented at the IWK now. It's the first site in Nova Scotia, and it's the new clinical information system that has totally changed the way that everyone documents, and the medication process has totally changed from, classic pen and paper to scanning barcodes and completely electronic charting. So that's kind of the purpose for doing some post-OPOR observations to see if those processes are actually being expedited at all or more seamless. So we'll be interested to see kind of how things have changed once OPOR and people are more settled in the new process. And that is all we have. We plan to only have till 12:30, so we sped through that pretty quick, but I'm happy to chat and answer any questions that people might have.
Awesome. Yes, we've got lots of time to have a fulsome discussion, ask questions, share ideas. I will turn it open to yes, Marilyn, you get to go first. Go ahead.
Yeah, hi, thanks. That was great, Sarah. And of course, this was a topic that was part of my work more than a decade ago. I did some work in this area from a patient safety perspective. But I think a couple of times you mentioned the reconstituting of medications. And I know that, it's like a long time ago, there was a total move away from that, just because that in itself is such a huge opportunity for error. And that there certainly are exceptions when time dictates that the pharmacy isn't going to get it to the area in a timely way. So there is allowance for that, but it certainly wouldn't be considered standard procedure. Just wondering if that, it sounds like it's a regular thing, and that just surprised me.
Yeah, it's definitely best. Like the ideal practice is that I think pharmacy prepares all of those IV medications and then they're brought up to the unit so nurses don't have to do that part of the process. But we definitely found that it does happen, I think, more often than we realize, especially if it's a new prescription of an antibiotic that needs to be given urgently. Sometimes the time to wait for pharmacy to prepare that isn't there, as well as on weekends and in the middle of the night, often when people get sick and pharmacy's not there anymore. A lot of the times it is nurses that are doing those tasks as well. So we were able to capture that for sure. Not always. There was definitely lots of instances where pharmacy had prepared those medications and nurses were using the pre-prepared medications. But yeah, I think we saw a bit of both.
Yeah, and I think too, we really tried to get a wide variety of what times we were going, so that we could capture that. So we did do some evenings as well, going into when pharmacy was no longer available, including some weekends where, like Sarah had said, where they are no longer there after, I believe it's 4 p.m. So we could capture some of that information as well, because any new admissions coming in, any new orders wouldn't be seen by pharmacy after that.
And something that I didn't mention in the presentation, but a lot of our discussion when we were planning this study was about like work as imagined versus work as done. So work as imagined being, you know, in a perfect world, if everyone's following the policy and everyone's fully staffed, how are things going to roll out? But we really wanted to capture what's the reality of nursing like medication management, and how do these things kind of stray and what causes those workflow interruptions.
And it speaks directly to process. I mean, if there's only pharmacy 8 hours a day, like that shocks me in the
Yeah, I think there's
times
usually
we're
someone
living
on
in.
call, but not necessarily for things like that. It would be more emergency
Yeah.
situations where they really needed pharmacy consult. But yeah,
So
and
then the
again, we can't
standard, in other words, the standard only applies 8 hours a day.
Yeah.
Yeah, and we can't speak to how things work in the adult hospitals because we've only done this at the IWK so far. So I'm not sure. I can't really speak to how that process is in the other centers. But yeah, at least in our case, it seems to be kind of a business hour approach.
Wow. Thank you.
Yeah, no problem. Thank you.
Go ahead, Karen.
Oh, I have so much questions and things to say. Such a great view of the environment. I really like that you're looking at the environment, like, so what really happens, you know? But most of my experience in the last couple of years before I came to Dell was working professional practice and a lot of medication management with home health nurses. And I'm curious, you know, of course, in the home, the observation piece wasn't there, but we ended up doing a whole policy and a guideline on the rights of administration because we were having so many med risk events with medication errors, whether it was timing, whether it was, you know, a whole bunch of different, but a lot of it was environmental factors. So I really wondering if you're going to be, I mean, I know you're looking at behaviors and timing and process. Will you be pulling in any, you know, event errors, medication event, adverse medication events, whatever they call them at IWK, to link that to see if that has any impact, or that's a whole other separate kind of study?
Yeah, I feel like it probably would be a whole other
Yeah.
study. We
Yeah.
really wanted to shift for this study because there's been so much work done on medication errors in the past. We really wanted to shift the focus from errors to more of like contextual things. And it also, we felt that we would probably get more buy-in from nurses because it's always awkward to be observed, right? And if we come in with, you know, we're auditing them and trying to catch errors, we were a little bit worried about just the ethics of that and also just people's willingness to participate in the study. So we wanted to make sure that participants knew, like, we are not coming in to scrutinize your practice. Like, we are nurses. We understand, like, the practice. We both are RNs at the IWK. So we're, you know, familiar with the policies and the practices. So we really wanted to shift away from that. Mostly to give nurses and managers an opportunity to share their experiences and kind of capture what those influences are, like those environmental things, like you mentioned, that aren't always captured in policy.
Yeah, that's great. I was just thinking of the,
Yeah.
you know, relating it to, like, here's why, you know, we're short-staffed or incident reports go up or don't have the same
Exactly.
patients on our caseload in a week. Then here's why. Just thinking about that. But I also thinking about, as I'm getting more into the clinical education side of things, like our students, right? Because you look at the textbooks and it's like, here you go, you do this.
Yeah.
Like,
In a perfect world.
there's nothing, you know, and then in the lab, like, they're doing the testing and they're doing, but there's not of that. Well, where are you going to do this? What's it like? Who's going to be talking? How many people are in the med room when you're getting your med prepared? Who's coming and going when you're going down that hall? Like, very interesting that, you know, those environmental, those contextual things that of the day to day in a lot of what we do in nursing isn't really part of the process. How are you going to deal with those interruptions and focus on safety? I think it's always about focus on safety. And then the med math, you know, how long does that take, and the safety of that. So anyway, I think it's going to show some good stuff and help us kind of think about how we can bring that context into the lab and the teaching.
Yeah, there's so much we could be here for like hours and hours talking about all the data that we got. Like I wish we had time to share more. But we were able to capture, like, if there was an interruption, where was it taking place? And a lot of them are in the med room because there's 10 people in the med room waiting to get into Pyxis, and everyone's chatting and asking about your weekend and whatever. And that's just the reality, I think, of working in a setting like that. So we were able to capture those things, which was really cool because, like you said, none of that is really taken into consideration in terms of policy and practice. It's really like in that perfect world scenario, but that we're hoping for, but that's never really the case. Thanks, Karen.
Awesome. I wasn't sure. I know, Lisa, you had your hand up and down, but then there's some stuff in the chat. Sarah and Chloe, do you want to take a peek at the chat?
Yeah. Oh, Lisa, did you?
Oh, go ahead, Lisa. Yeah.
Thanks. I started to type and I thought, I'll just wait and raise my hand when there was an opportunity. I think this was just great. From reflecting on my own clinical practice, I really appreciate that you guys were looking at, the pieces that I think nurses have often self-reflected on when filling out SIMS reports or AIMS reports. I often think about, near misses and, including information about where those interruptions were happening, but I don't think there's been a lot of great research that captures that. So this is fantastic. Really well done.
Thank you so much.
Yeah, no, it is. If I may ask, I've got a few questions, but I will just ask one. I'm just curious about the qualitative piece and the focus groups where you're talking to nurses, and it's just nurses, right?
Nurses and management.
And
but most of
management.
them are nurses. Yeah.
Right. So I'm just curious if you have, or you might be asking them about just their thoughts or their feelings. I'm wording it in a particular way about medication errors in general, because you talk about the system and where it is. And I know you're observing nurses. Sorry, I'm taking a little bit of a long time to get to my question. And I'm asking the question partly because I worked in medicine for a while as a nurse, but I haven't worked there in years. But if I have a nightmare, it's usually about medication errors. And I've never had one, right? So like, where does that come from a nursing perspective? So even the nurses who have not had any medication errors, just, what do they feel about it? Because it's serious and there's all sorts of checks and balances and it, informs their practice. And, again, I haven't worked in that area for a long, long time, but just curious about that piece.
Yeah, it definitely is a huge fear, I think. And I think a lot of it one of the questions we asked, I can't exactly remember the exact question we asked, because it was very conversational. Once the focus group was happening, everyone had lots to say, which was so great. But we did ask a lot. We did ask a couple questions related to like unit culture, because I think that has a huge influence on people's willingness to report errors or talk about errors or ask questions, things like that. And I know for me, starting as a new grad, I was really lucky to work in a place where people were very open. And if mistakes did occur, it was a very, very much okay, like what can we do to help you make sure this doesn't happen again? More rather than a punitive, you're in trouble for doing this kind of approach. So I think a lot of it had to do with the culture on the unit. So we did get some information about that, and without sharing too much because I don't have it in front of me, but for the most part, I think the unit that we observed on had a very similar culture where they were all very open with each other to talk about potential medication errors and things like that. So generally, the impression I got was that folks were, of course, cautious about medication errors and nervous and not wanting to make them, but thankful that they worked in a place where the conversations were happening in an open way and that people weren't feeling like they were going to get fired if they made a mistake or if they had a question, things like that. I don't know if that answers your question. I wish I had more to share about it, but.
And
go ahead.
Sorry, I think too, like you had mentioned, it can be really, really daunting to think about, like, oh, if I make a medication error, what's going to happen? Like, how bad can it be? And I think a lot of nurses have that mindset of like, it's only your fault. If you make a medication error, there's nobody else to blame. And while we have all those safety checks in place to try to prevent that, this study, I think, also shows that there's a lot of other factors that play into that. Like those interruptions can be taking you away from doing the correct math on a medication that you're preparing. So I think having this information and showing it to them, they can kind of realize like, okay, there's other factors. How can we help those other factors be limited moving forward?
Yeah, no, amazing study. I mean, and I just love the methodology and your quantitative piece, your observations. Yeah, and connecting it to the system. I think that's really powerful, and that'll be so unique about what you're doing. Yeah, because you think about, the prescription, who does that, and also the dispensing. So there's so many other layers, right? And nurses catch things all the time, right? So, yeah, no, it's just fascinating. I saw someone else asked about the OP, one patient, one record, and I also curious about that, what it's going to be like after. So how long are you going to wait? Because putting OPOR, which just started in December, like how long will it take for people to become comfortable, or I don't
Yeah.
know. Had you thought
I
about
think
that?
that's kind of a question that we have been toying with recently, I think.
Yeah.
We're kind of leaving that a little bit up to the units as well and seeing when each unit feels comfortable to kind of welcome us back to doing more observations. Because if we go and they are kind of all over the place because of this new system that they're trying to work out all the kinks of, not just related to medication administration, but just nursing practice in general. I think it would definitely make it a lot more difficult to get accurate information and accurate observations during that time period. So it's kind of, I think, going to be up to like a unit by unit decision of when we go back to doing the observations and how comfortable each nurse feels, how comfortable the management feels, and those kind of things. But I do definitely think we're going to see some differences. Like, I think we'll see differences in like bracelet checking because that was something that's on our checklist as well. Because now you have to scan the bracelet of a patient before you even give a medication. So I think we're going to see definitely some changes, maybe a little bit more time on medication administration because there's more steps now in terms of you have to bring the cart down with you. You have to go in the room and scan the bracelet. You have to then come out and scan the medication, those kind of things. So I think we'll see a difference in where our time is spent during the medication process.
Yeah, and when we developed the checklist, we had OPOR in mind. We knew it was coming, so we tried, and we don't know for sure yet because we haven't done it yet. But we tried really hard to make the checklist applicable to post OPOR changes as well. So we included, the barcode scanning and the wristband scanning in the checklist, knowing that we would probably be back doing it again. And yeah, we're hopeful that we can maybe do observations with the same nurses again, because just for consistency's sake to see how things change. And I think we'll see differences, of course, very recently post implementation, but also if we end up doing this again, maybe a year or two down the road, I think things will change even more by then. So yeah, it's hard to predict what will happen. I think some things will take longer and some things will be more expedited, but yeah.
Yeah,
It'll be interesting to see.
for sure. Yeah, and yeah, brilliant. You're taking that into consideration. I'd be really interested in what would be happening, like right, from December, like just as you kick it in, right? So before, during, and after.
Yeah.
Because, talking to a few nurses who are doing this, they, there's some concern about how this is really impacting the flow, especially in high acuity areas and all of that. So, and I know,
Absolutely.
yeah, I mean, it would show something different probably, but
Definitely.
I get it. But how do you make these decisions, right? You only have so much money and so much time to do a study. So yeah, just waiting to, but I love that you're just waiting for them to tell you when they're ready, right?
Yeah.
Obviously. Yeah.
Yeah. And from a safety perspective, like we would never want to go in and add to that
Right.
distraction and chaos by hovering over someone's shoulder as they're trying to figure out what they're doing. Like I know as a nurse myself, I'd be like,
Yeah.
absolutely not. You're not coming to observe
Yeah.
me 2 weeks after OPOR. Like that's not going to happen.
No.
So yeah, we're letting them kind of lead the way as of right now. But I think as far as I know, the unit that we did complete is interested in us coming back soon to do it again. So we're just, it's coming, but we're not quite sure when.
Yeah.
Well, that's true. Yeah. You can do a retrospective of what they felt went on during that time.
Absolutely.
Yeah.
Yeah.
Great. Other people, comments, ideas, questions? I see someone typing, so we'll just give like another minute, see if there's anything going on. Yeah, I mean, oh, Emily, go ahead.
Hey, so I think I might just be repeating the one I'd already written down, but I'm just curious, like, what the context of this question is. Post OPOR implementation, I made a med error on the floor. So I'm wondering what you're thinking you might see. I'm just curious, like, what the hypothesis is for your post OPOR observations.
Yeah. We're not capturing like medication errors in our checklist. Like we made it very clear that we were like not going to be auditing them and tracking medication errors just for comfortability's sake. Like any med errors would be managed, of course, per policy of the unit. But that's not something that we were going to capture. But I do think if we were to go back in right now, I think we would definitely see things taking a lot longer in terms of even just doctors ordering medications is taking longer because they're still trying to navigate the system and find where they need to go to make those orders. And then, but I do think there would be probably some things that take less time now. With getting rid of paper charts, I think, like trying to find your chart, who has your chart, like what doctor has it and what room are they in, things like that would be kind of expedited now, I think.
And one thing specifically that I think would be completely gone is like the transcribing, because you're no longer having to take the order that's on paper and write it onto a paper MAR, goes into a computer, automatically goes into your computer MAR. And then you just have it there. We obviously are still expecting nurses to still be doing like double checks of medication doses and things like that. But even that, I kind of assume that we might see that a little less as well.
And I feel like we'll probably see a lot more multitasking and interruptions in terms of just people being like, how do you do this again?
Yeah.
And like asking their colleagues for support and things like that. I feel like we would probably see that a lot. So just like work-related conversations that are that nurses are engaging with during that process.
So, okay, anyone else? Great. Okay, well, I'm going to thank both of you, Sarah and Chloe, for amazing presentation and amazing research. It's always wonderful to find out what people are doing, and you're moving quite along. So thanks for sharing. Like, I know you're not finished the study yet, but great to hear what's going on. So wishing you well. And thank you to everyone for coming to our Wednesdays at noon today. And we will see you in a couple of weeks for our next one. All right, thank you.
Thanks, everyone.